Oral Abstract Session 1A. My name is Sadia Sadiqzada. I'm a psychiatry resident at the University of Toronto. I'm excited to be here today as a co-chair. I'm also here with Beate Jan, who is from UMIT in Austria, and she's the VP-elect of SMDM. I want to thank SMDM for having me as a co-chair, particularly as an early investigator. This was a really wonderful opportunity, so thank you. I'm going to establish a few ground rules when it comes to presenting here at SMDM. They're rooted in respect. So we demonstrate respect for others through clarity and brevity in our interactions with oral presenters. We believe that criticism should always be constructive, balanced, and actionable. We acknowledge the value of work, even as we identify concerns or flaws. We always provide criticism with the goal of making the work better. So today we're going to have 6 oral presentations. Each presenter will have 10 minutes to present. We will give them a 1-minute warning. They also have a timer up in front of them for them to keep track. After that, there will be an opportunity for a question and answer period for 5 minutes, again, rooted in respect for our presenters. And we want to make sure that comments are hopefully phrased as questions. And if we get the sense that it's becoming run-on commentary, we will have to interrupt and make sure that we are on time. So without further ado, I'd like to present the first presentation. So this presentation got me thinking a lot about my grandmother. So my grandmother right now is considering elective total knee replacement bilaterally. Just chatted with her about that last Friday. And so Hassan Romraoui is presenting incorporated outcomes data from large registries and administrative databases to improve appropriateness criteria for total knee replacement. Thank you.
Thank you for the opportunity to present our work. The title is Incorporating Outcomes Data from Large Registries and Administrative Databases to Improve Appropriateness Criteria for Total Knee Replacement. We have no relevant financial disclosures. However, this research is supported by a grant from NIAMS. Total knee replacement is an effective and cost-effective elective surgical procedure for patients with advanced knee osteoarthritis. Currently in the United States, more than a million procedures are performed, and the numbers are rising rapidly. When patients and surgeons are considering a total knee replacement, the decision is driven by mainly 2 main characteristics or findings. First are the pain and functional limitations that the patients have, and the imaging findings from X-rays and MRIs. However, because this is an elective surgical procedure, other factors come into play, such as expectations of outcomes, sociodemographic factors such as age, race, and sex, the patient's comorbidity profile, and clinical practice variation. As a result, research shows that patients undergoing total knee replacement have a wide range of pain and functional limitations, as well as of X-ray findings. Timing of total knee replacement is very important, therefore. If the surgery is performed too early, patients derive little benefit in terms of pain and functional improvement. They are also subject to unnecessary risk of post-operative complications, and they are also at an increased risk of revision surgery, especially if they do the surgery early on. On the other hand, if the surgery is performed too late, the damage caused by severe osteoarthritis of the knee causes a lot of limitation and is associated with additional comorbidities such as CVD. If and when the surgery is performed, the surgical outcomes are much less desirable than if they were in a more timely fashion. Appropriateness criteria for TKR are evidence-based methods to help patients and surgeons decide whether TKR is appropriate or not. Over the past 20 to 30 years, a number of appropriateness criteria have been developed to help determine when a patient is appropriate for TKR. However, despite the association between timing and outcomes, none of the existing appropriateness criteria have included outcomes. They've all focused entirely on clinical presentation factors. So the aim of our study were to develop new appropriateness criteria that include predicted outcomes by amending existing appropriateness criteria. And we focus on the modified Escobar appropriateness criteria for this. Once we've developed these new criteria, we do CART analysis to determine the relative importance of predicted outcomes compared to clinical presentation factors. The predicted outcomes that we chose to focus on are three: risk of serious complications, improvement in pain and function at 2 years after surgery, and risk of revision surgery. All three outcomes are established outcomes in the orthopedic literature. So why did we choose these outcomes aside from them being established outcomes in the orthopedic literature? Is because in the past 5 to 10 years, most of these outcomes have become standard. They've been collected in national and international registries. And I give the example of the FORCE TJR registry, which is a nationally representative sample of more than 15,000 total knee replacements. And this registry has been collecting pain and functional follow-up data on these patients. And why did we choose to start with the modified Escobar appropriateness criteria rather than starting from scratch? First, this criteria is derived using the validated modified Rand Delphi method. It's the simplest of the existing criteria, only 16 clinical scenarios, and based on 5 factors, and has been associated with outcomes. So the collective judgments of these patients, of the clinical panel, is associated with outcomes. To do so, we did this in 2 steps. First, we developed the criteria, and then we did the CART analysis. To develop the criteria, we assembled a clinical panel, 9 clinical clinicians, 3 orthopedic surgeons, 2 rheumatologists, 2 general internists, 1 physical therapist, and 1 orthopedic nurse. We worked with the orthopedic surgeons to define the categories for the predicted outcomes, and then to develop the scenarios, and then had the surgeons rule out the clinically implausible scenarios. Once we've done so, we had the entire clinical panel rate the remaining scenarios for appropriateness. What did the orthopedic surgeons say when we talked to them about the predicted outcomes? They helped us develop 3 categories for each of these predicted outcomes, and we ended up with 27 potential combinations of these outcomes. When you add those to the 16 Escobar scenarios, we ended up with 432 mathematically possible scenarios that then the surgeons ruled out a bunch of them, and we ended up with 279 scenarios. And then the entire clinical panel rated these scenarios for appropriateness using a defined method where each scenario is rated on a 1 to 9 scale. We got the median of the 9 ratings, and then the median was categorized into inappropriate, maybe appropriate, and appropriate. So of the 279 scenarios, we ended up with 71 inappropriate scenarios, 112 maybe appropriate scenarios, and 96 appropriate scenarios. Then we run CART analysis to determine the relative importance of the predicted outcome factors compared to clinical presentation factors in the decision-making process. And I think for sake of time, I won't go through the CART analysis methodology, but I would just want to share with you the decision tree that came out of this CART analysis. Obviously, I don't expect you to read through the tree, but what I want to show you is this. The rectangles, the blue rectangles show the predicted outcomes, and the red rectangles show the clinical presentation factors. And as you can see, the 3 predicted outcome variables that we've chose all made it through on the tree. However, only 2 of the 5 clinical presentation factors made it to the tree, which shows that predicted outcome variables were important in the decision-making for clinicians. So in conclusion, we have incorporated predicted outcomes into the appropriateness criteria. We have shown through the CART analysis that clinicians favored predicted outcomes over several clinical presentation factors in their decision-making process. This demonstrates the potential use of having these data available to clinicians and patients to help in the decision-making process. And while the findings are not entirely novel, while the findings are potentially novel in orthopedics, they're not entirely novel in medicine. Cancer patients use expected or predicted outcomes on survivorship to feed into the decision-making process as to whether they undergo an intervention or not. Obviously, now that we've developed these criteria, they are not, our job is not done here like any researcher, but really the next steps here are to develop the software that would link these scenarios to actual registry data and large administrative databases, and to develop some of the remaining prediction models so that this is an actual working appropriateness criteria. And then once we've done that, an important next step is to validate these criteria for patients against real-world outcomes. Our work has some limitations. Because we relied on the modified Escobar criteria, there might have been other important clinical presentation factors which we have not been included. There might be other outcomes of interest to patients, such as satisfaction, which we have not modeled here. And the clinical panel may not be representative of all experts in the field. Thank you.
Thank you so much, Hassan. So now is the opportunity for Q&A. I see someone getting it. Perfect.
Very interesting work, Heather Gold from NYU. I'm wondering if all of your clinicians were who were part of the process there.
Clinical panel?
Yes. Were they all from the same institution? And if they were from the same institution, were they from little offshoots? Or because folks tend to practice the same way within the same place, and I wanted to get a little sense of the variation there.
Yeah, actually, I didn't have time to talk about the clinical panel, but certainly there were some clinicians from the same institutions, but this is a multi-institutional panel. For example, the orthopedic surgeons, there are 3 of them. They are all high-volume orthopedic surgeons. However, each one of them is from one institution. So for example, I have one from the Hospital for Special Surgery. He's an African-American. One of them practices in Kaiser Permanente in South California. And one of them is from Northwestern, and he's also a high-volume orthopedic surgeon. I think the only clinicians who are from the same institutions who have the same kind of specialty are the rheumatologists. But they also practice slightly differently. One of them is a rheumatologist who focuses on knee OA. And the other one is a rheumatologist, but she is also in charge of preoperative screening or preparations of patients who are undergoing total knee replacement.
All right, thank you so much, Hassan. We're just going to stop here because we're at 3 o'clock. Okay. Thank you.
Next, we welcome Olga Gostopoulou, and she will talk about the use of diagnostic decision support can reduce bias in clinical documentation.
Okay, hi everyone. This is work that I did with Chris Treacy, was a master's student at the time, but also a GP, a general practitioner, a family physician in the UK, and my colleague Brendan Delaney from Imperial College, who's also a GP. We have no conflicts of interest. So why do physicians document the clinical consultation? For a number of purposes, predominantly to monitor performance for targets, to see whether targets are achieved, and for billing, audit. And we know that coding using clinical codes is kept to the minimum necessary to achieve those first two purposes. Unfortunately, then this has implications for learning when things go wrong, and also research, because a lot of clinical evidence that drives clinical prediction rules or clinical risk scores and guidelines is based on routine data. And if the documentation is incomplete, then we can be in trouble. So I interject here to briefly present a diagnostic decision aid for general practitioners that we designed some time ago. Its defining characteristic is that it suggests to physicians possible diagnoses to consider very early on in the consultation. As soon as the GP enters the presenting problem, it then uses information from the electronic health record, such as patient demographics and risk factors, to present them with possible diagnoses to consider. And this is what it currently looks like. So you see on the right-hand side the possible diagnosis. It's a long list. They can actually click on any of these diagnoses, which then opens up a box of symptoms and signs that are related to that diagnosis. They can click if they're present or absent. They can also enter information as free text up there that says signs, symptoms, and examinations. And via predictive texting, they get a drop-down menu. They can select the right thing they want to enter. And all the coding happens at the background. They don't have to enter any clinical codes themselves. And as more information is entered, the order of the diagnosis on the right changes. So essentially, it also facilitates coding in real time, because you don't have to enter any codes yourself. And it motivates coding because people like to see the list changing and like to interact with it. We evaluated this in a previous study with 34 GPs who consulted with 12 actors. 6 actors they consulted with their normal electronic health record, and 6 different actors, patients, with a diagnostic aid that was integrated with the electronic health record. We found significant improvements in diagnostic accuracy and a huge improvement in the number of data items coded into the electronic health record. We also observed that most of the GPs, when they just used their electronic health record, they documented after the patient had left the room, and mainly free text. The problem is then you may have memory gaps or memory distortions, or you may be simply justifying the diagnosis you've just given. And in a quite an early study, Arkis and Harkness found that after we make a diagnosis, we tend to mistakenly recognize new symptoms related to that diagnosis as having seen them before, and not recognize inconsistent symptoms with that diagnosis that we have actually seen before. So we create, after we give a diagnosis, we create this coherent picture of the patient that's consistent with that diagnosis in memory. And as early as 1980, they suggested that to avoid such memory distortions, the diagnostician would be well advised to record not only the diagnosis, but also all symptoms actually observed. So, of course, that doesn't happen. Our hypothesis was that clinical documentation is consistent with the diagnosis the physician gave and may not reflect accurately how the patient presented and what was observed during the consultation. But how can we test this? What is the comparator? It could be the documentation by different doctors who gave a different diagnosis to the same patient. That's not that easy to obtain. Or you can have an ideal complete documentation, which we don't have. What we used was data we already had from the evaluation study of the diagnostic aid, but we knew that documentation was likely to be more complete than usual practice. So we used this existing data set, which consisted of all the data that our 34 GPs in the previous study I mentioned documented during the 12 consultations. As I said, half of the consultations were without the aid and half of them with the aid, both coded and free text data. Now, some of these data were already predefined by us in order to make up the scenarios that we gave to the actors to act out. So, for example, In this table, you see there are about, how many? 28 symptoms and 8 signs that we had already predefined in the scenario 2, and a particular GP documented some of these things in their consultation. So the green is what they documented in free text, in yellow what they documented in code. And we did this for every GP and every consultation they did. So that's quite a lot of data. We also wanted to find out how much of the data that they documented were relevant to their final diagnosis. And in order to do this, we had 5 GPs totally independent, not involved in the original study. Actually, they were friends of our master student GP, who saw the list of the predefined clinical data that I've just shown you of every of the 12 scenarios, every scenario. They also saw the list of the diagnoses that the 34 GPs gave to each of the scenarios, and they indicated independently which data were relevant to each diagnosis. And if more than 2 GPs said that a datum is relevant to a diagnosis, that we also, we designated it as diagnosis relevant. We then analyzed, we compared usual practice versus aided practice via regressions, and this is what we find. So on the left-hand side, we've got the usual practice, EHR only, right-hand side, EHR plus diagnostic aid. So we see that on average, when they use the aid in the consultation, they tend to document 4 more data items. And when we break this down, we see that the blue bars are, again, all the data items documented. The red bars are the coded data items. So we see a big increase in the coded data items. The green bars are the free text items. So when using the aid, they record much less free text data. In terms of the proportion of the diagnosis relevant data out of all the data that they documented, we see that in the usual practice, they document a higher proportion of diagnosis relevant data than when they use the aid. And when we look at just the coded data in clinical code, we see that in the usual practice, in over 60% of the consultations, the coded data they enter are relevant to that diagnosis. So we think that using the diagnostic aid, we see that using the diagnostic aid increased the total amount of information documented via documenting more coded data, mainly, and reduced the proportion of information that was relevant to the GP's final diagnosis, which we suggest results in a more balanced record of the consultation. Of course, we don't know whether these differences are due to the way they searched for information. So maybe they just searched for one diagnosis, and this is what they documented, or the way they documented. Maybe they documented preferentially for that diagnosis, perhaps because most of them were documented after the patient had left the room, okay? And we've got these problems there, as I explained earlier. But the implications are quite important, because epidemiological research that uses routine data can lead to inflated positive predictive values for symptoms and signs. So we need better documentation for discovering new knowledge, but also better learning and feedback.
Thanks,
Thank
Olga.
you.
The floor is open for questions.
Hi there, Bronson Tucker Edmonds, Indiana University. Really fascinating. I actually always love your work because you are trying to get into the minds of how clinicians make decisions. And what strikes me though, and I guess the question that I have for you with regard to kind of how you framed it in terms of where the EHR is intended to be useful and why we document. I guess I didn't see there that we document as a mechanism to communicate with one another in terms of clinicians to clinician and taking care of a patient longitudinally. And that was where I wasn't entirely sure about the conclusion with more being more. Like I take, for example, that right now, one of the real challenges with EHRs is that people copy and paste things forward, right? Or they have all their templates. And so there's tons of information, but a lot of it's not usable. So then as you're trying to like distill and find what is relevant and high yield, there becomes almost a question about whether you're more likely to miss things or things. So I'm trying to reconcile those two pieces of like where I definitely see the utility from the scientific standpoint. I'm trying to map it onto sort of the clinical case use for documentation in terms of whether or not more information, even if it's better information, may undermine one of the uses of trying to be more efficient in our communication with one another.
Yeah, I think I'm much more interested in the epidemiological use of it.
Sure,
So
sure.
the generation of knowledge. And also the fact that I would be concerned knowing that the physician will document things after I had gone, because that's problematic, right? Because they...
Oh, but that's how everything happens. Unless we
I
have
know,
hour and a half long
it's the
interactions
same.
with patients. That would be awesome.
Yeah. So it wouldn't be great if we could find a way that we document as we go along.
That'd be awesome.
Yeah.
Everyone would love that.
So that's the goal, right?
Olivier Rouen from University of Montreal. So I'm a clinician scientist. And on that point, I would be curious to see maybe one way to get interesting data, because I agree with most physicians just said it's not realistic to fill in the chart as we speak to the patient. It's probably not what patients want either. A lot of people get really annoyed when there's a screen and we interact more with the screen than with the patient, but that's a different story.
That's my next talk.
Yeah. No, but I'm just curious whether you could take advantage of maybe a natural experiment where some clinics and some emergency departments have started using scribes. So a second person in the room whose job it is to document live the interaction between the physician and the patient, and whether coding this way would actually be more accurate, be more complete, and be maybe more reflective of what the interaction is. Yeah, just food for thought.
Yeah, I didn't know about this, but that would be amazing. That would be my ideal complete documentation that I mentioned earlier. So that would be great. Do you do this here? Has it been tested? Has it been evaluated?
I don't know about complete data, but they've been doing acceptability and
Oh, I'll look into it. Yeah. Thanks.
Okay, so I think we'll pause there. Thank you so much, Olga. So she's actually presenting the next oral presentation,
Yeah.
so I'll introduce it. The next one definitely got me thinking about, I'm not sure if you saw in JAMA Pediatrics, I think it was in 2010. It was a drawing by a pediatrics patient of their interaction in the clinic with their pediatrician, and it's a really striking pencil drawing image. Essentially, the patient is sitting on the patient bed, their child, facing their parent, and the pediatrician is facing the computer with their back towards the patient. It's a really striking discussion around the use of computers and live scribing, et cetera, and the impact it can have. So without further ado, we'll ask Olga to present using a diagnostic aid changes physician behavior in the consultation.
Thank you. I actually had a GP exactly like that. I was sitting behind him, but okay. So this is related to this study, the evaluation study with the 34 GPs that I just presented, so which is great. I don't have to talk about it again. What have I done? So yeah, we have no conflicts of interest. So as a reminder, 34 GPs, so 12 standardized patients, and that's what we found. But what's the impact on the consultation? Okay, this is just one of our actors with the GPs. So what happened in that study, after every time an actor came out of the consultation room, they filled in a consultation satisfaction questionnaire. It's a standardized instrument, and we found no differences in the scores between the usual practice and the aided practice. But they also could write free text comments on the questionnaire, and we found that in 3% of the consultations of the normal practice, they said that the doctor was looking at the computer too much. And in 15% of the consultations when they were using the aid, the actor said that the doctor was looking at the computer too much. So we wanted to see what's going on. We actually videotaped those consultations, which we analyzed now for the presentation I'm going to do now. We annotated the observable activities in the videotapes, and then we compared the differences in the observable activities between usual practice and aided practice. To develop the annotation framework, we consulted various models of the clinical consultation, which we had to adapt to include using the computer and the electronic health record. The annotation framework was comprehensive, so we had to annotate everything we saw. It was also, the categories were mutually exclusive. And we went through iterative process of developing it, and we had a patient involved in the process. So at the very top level, it looks like this. The categories are doctor talks to patient, patient talks to doctor, doctor and patient interact with computer, silences, and anything else like signposting, formalities, etc. And then each category is expanded for more detail. So for example, doctor talks to patient while looking at patient or while interacting with a computer. And again, each of these things get expanded. So talks to patient while looking at them to ask a question, and then what kind of question, or to provide information, and so on and so forth. We then created a timeline of the consultation by time stamping the observable activities using ELAN. I don't know if you've ever come across this. It's a freely available software for video annotation. And it looks a bit like this. You have your videotape there and your annotation framework on the bottom left-hand side, and you timestamp everything in milliseconds. So you end up with a lot of data. To synthesize the data, we used Fluxicon Disco. Funny name, I know. Another freely available software, which is for that purpose, it synthesizes large data sets of annotated activities. It does all sorts of things, process mapping, but we mainly used it to synthesize the frequency and duration of observable activities. I didn't find it that helpful because if you've got a detailed annotation framework, it doesn't add up subordinate activities into superordinate activities in some meaningful way. So we had to do this manually, essentially. So all the different questions into the bigger question category. So for the analysis, again, we compared aided with unaided practice. So we found that the GPs, when they used the diagnostic aid, they asked more questions, on average 3 more questions. The consultations lasted longer, on average less than a minute. So it's not a big difference. There was less eye contact, on average a minute less, and there was more computer use. When we look at the questions that they asked the patient, now the orange bars are all the questions asked. The blue bars, the first bar is the open questions, and we see no difference between aided and unaided consultations. The red bars are the questions that required elaboration. So, do you have any other symptoms? It could be answered by yes or no, but then if it's yes, then you need to elaborate. And then the green bars are the closed questions. So we see that there's a difference in those targeted questioning. So they ask more targeted questioning when they use the diagnostic aid. In terms of the proportion of time spent on the computer, Out of the consultation duration, we see that when they use the decision aid, of course, they spend a bit more time. And when we look at when they interact with the computer, again, the yellow bars are the duration of the consultation. The green bar, the third bar, is the total time spent on the computer. So you can see proportionately they spend more time on the computer when they use the aid. The blue bars are they use the computer while the patient is there. And we see that they use a lot more of the computer when the patient is in the room. And the red bars are use of the computer when the patient has left. So that links back to my previous talk. So of when they document. So when they use the aid, they document a lot less. They use the computer a lot less when the patient has left. We found no differences in the time that they took to discuss diagnosis, and a difference in, they spend less time discussing management when they were using the aid. But you can see this is tiny, very small differences. And of course, because it's a totally exploratory study, the more tests you make, the more likely you are to find differences. These are actors. They were actors. They were not patients. So they didn't engage with the computer. They weren't really interested to find out about their medical problem. So we would expect when you have a patient in the room, they'd be a bit more interested in interacting with the computer. So we didn't have the opportunity to study that kind of interaction. But we can tell that it changes the dynamics of the consultation, predominantly how GPs record. And also more time spent on computer, as you've already said, and less eye contact with the patient may be perceived by some patients, not necessarily by everyone, by some patients as the clinician having lower interest or less empathy with them. But it could also have some positive impact because giving more information may make them more involved in the consultation and the decision making, may motivate them to get more involved. And we're planning a future study to see how this impacts on real consultations with real patients. That's all.
You did great on time. Thank you so much.
Olga, this is fabulous work. Obviously, it's stuff I'm really interested in. The actors, did the physicians know they were seeing actors?
Yeah.
Oh, okay, great, thank you.
I wish we could do what you've done with the unannounced.
One question that I had was, and I'm sorry if I missed this, there's a lot of talk about the methods on how you did this study, but I'm not sure that I understood what type of decision support system the physician used. Like, what was the clinical scenario? Was it a wide range of clinical scenarios?
It was a huge range because these are general practitioners. Yeah, so because these are family physicians, it was a wide range of scenarios, not only in terms of content and diseases, but also in terms of difficulty, ranging from really, really simple problems to quite hard problems, where we also saw most of the effect of the intervention.
I'm wondering what your next steps are.
Yeah, so we're, firstly, we are trying to develop this diagnostic aid by improving its knowledge base. And then we want to see how it impacts on the actual consultation with real patients and what the patients think of it. Yeah.
Oh, I think we have one more.
Chetan Puturajpa, University of Pittsburgh. Those consultation sort of the decision aids that you're using, is there data that they reduce the diagnostic errors, or by how much in general, sort of in terms of improving sort of diagnosis?
Yeah, you mean in absolute terms? I don't remember, but
so one sort of follow-up question I have from that is there a concern that sometimes these may lead to, for example, if the physicians are asking more questions based on a prompt, they may do that despite them thinking, correctly that it may not be appropriate for that patient. So is there a potential for you to do unnecessary tests or other things? Because sometimes
perhaps we had some quite easy cases, which didn't seem to matter.
So I speak from a personal experience because in the clinical training sort of setup, most physicians know this, that yes, you go from medical student training to residency to things, you start to synthesize data. Certainly there is the issue of anchoring bias and other kinds of biases that will many times lead you to make wrong diagnosis, but it's also this learned sort of eyeball or whatever the experience that comes with it that may allow you to omit certain questions that may not be important. So I was wondering, how do you balance out those two things?
As I said, this was designed to combat our first impression bias. So trying to open up your thinking to other possibilities. We didn't see any significant increase in investigations. There's always that possibility, of course.
Thank you.
Yeah. And I should also say that in the UK, we have a bit of a problem with cancer diagnosis and delaying cancer diagnosis, and our outcomes for cancer patients are worse than other European countries. So getting cancer diagnosis earlier is a way of improving that. So that's kind of playing in that area.
Thank you.
We have roughly 1 minute for one more question. Please
Awesome. I'll be
introduce yourself. and
Brief.
go ahead.
Yeah, thanks. Dan Pinto, Marquette University. Great presentation. What was the average length of this consultation, and does it match clinical practice?
Yeah, it was, did I show it there? Well, 12 minutes, something like that. Yeah, it matches. I mean, in clinical practice, you have 10 minutes as a standard, but you can go above or below that. But on average, it's about 10 minutes, yeah. So yeah, it did match it.
Thank you, Olga.
So next, we will learn about the role of recent adverse events in physicians' treatment decision. What passed is passed. Presenting Manaswani Singh, Memorial University. The floor is yours.
Yes, just 1 second. Oh, God. Quit. My God. Sorry. Okay. Hi, everyone. I'm Vinny Singh. I am a fifth-year doctoral candidate at Emory, and today I'll be presenting my job market paper for you guys. Okay. So before we dive into the paper, I just want to give you a quick overview of the research questions I ask and a sneak peek of the results. I ask, if a physician sees a bad patient outcome in one patient, is she likely to treat the next patient any differently than she would have otherwise? And I find that yes, she does. If she treats that next patient differently, does that affect that patient's health outcomes? Again, yes, I find that does happen. And is this physician response to adverse events, can it be considered to be plausibly in line with a Bayesian updating? And I find that it cannot. All right. So, like all individuals, physicians have been shown to rely on decision-making heuristics when making clinical decisions. In randomized control experiments, they have been shown to exhibit cognitive biases as a result of using these heuristics. However, the extent to which this happens in clinical practice is much less documented, and its effects on patient welfare are even fewer. In this study, I examine whether physicians use the availability heuristic when making decisions in the obstetric ward. The availability heuristic should predispose physicians to use information that comes easily to mind, such as recent adverse events that trigger a sort of emotional response. And to be fair, there are studies that have shown that physicians change their behavior after adverse events, such as they might prescribe a medication less or order more tests after an adverse event. but most of these studies do not address the extent to which this is optimal from a Bayesian standpoint. Is this response warranted? For instance, if a person gets into an accident, driving accident, he is expected to change his driving patterns after that. However, if he reverts to his usual style of driving after a day, that cannot be considered to be in line with optimal learning patterns. Okay, so I use 100% inpatient EHR data from a large academic hospital for this analysis. I have about 13,000 deliveries, 50 obstetricians over a period of 3 years. My independent variable, what I call adverse patient outcomes, is a count variable of about 9 maternal and neonatal adverse events as defined in the literature of obstetric care quality, because they've been shown to be sensitive to clinical performance more so than other events. My dependent variable, which I will henceforth refer to as physician switching behavior, is when one physician's past patient, her last patient, had delivery mode A, and her next patient, that is her current patient, has delivery mode B. Okay, so let's dive into my questions a little bit more. First up, do adverse events in delivery mode A in one patient make the physician more likely to switch to delivery mode B on the next patient? And before I present the results, I just want to orient you to the axes of this graph a little bit. So the y-axis is the probability of a physician conducting a vaginal delivery in her current patient. As the y increases, the probability of a vaginal delivery increases. As y decreases, the probability of a cesarean delivery increases. And the x-axis is the number of adverse events in that same physician's prior patient. Okay, so result number 1. What happens when the prior patient has had an elective cesarean? And we see this really clear dose-response relationship where as the number of adverse events in a prior cesarean increases, the probability of a vaginal delivery in the physician's current patient also increases. Specifically, 2 or more adverse events in a cesarean make the physician about 9 percentage points more likely to switch to a vaginal delivery on the next patient. Result number 2, what happens when the prior patient has had a vaginal delivery? And we see the results in the expected direction. However, the effect size are smaller and the effect is non-significant. Specifically, 2 or more adverse events in a vaginal delivery make the physician 1.2 percentage points more likely to switch to a cesarean on the next patient. And this asymmetry in effect size and statistical significance could be due to 2 reasons. One, in my data set at least, vaginal deliveries very rarely have adverse events beyond 3, as you can see by the increasing size of the standard errors. And 2, since vaginal deliveries are usually the norm in obstetrics, maybe physicians don't respond as emotionally to adverse events in vaginal deliveries as they would to those in elective cesareans. This is an analysis I'm not going to be able to cover in this presentation, but I just want to let you know that I also looked at whether an adverse event not only predisposes the physician to switch on the next patient, but does it also predispose the physician to switch to the unexpected delivery mode, maybe potentially the inappropriate delivery mode on the next patient? And it turns out that yes, that also occurs. And I've already shown you that prior adverse events affect the delivery mode choice on the next patient. But do they affect other sort of treatment patterns of that patient, for the patient as well? And I find that after an adverse event, if a physician switches delivery modes for the current patient, that current patient has greater treatment intensity as measured by daily inpatient charges, specialist consultations, and length of stay. Now, we have shown that treatment patterns change as a result of adverse events, but does that affect patient outcomes? Again, after an adverse event, if a physician switches delivery modes on the current patient, for that patient experiences worse patient outcomes. That is a statistically and economically significant increased risk in the probability of an adverse obstetric event and an increased likelihood of 90-day readmission. So to summarize, switching behavior after an adverse event is associated with greater treatment intensity for that patient and worse outcomes. Now, to what extent is this response learning? Are physicians just doing this as a way to get better, to have better patient outcomes? Is it a form of learning? So I set up a model of Bayesian learning where I have a physician with ability row, initial priors that are normally distributed. This physician has seen N patients, each with a clinical outcome Y. And I find that the probability of switching on the next patient, conditional on the patients before, depends on N, which is the number of patients seen by the physician thus far, and the innate ability of the physician. The predictions from this theoretical model are very intuitive. If this physician response to adverse events is a Bayesian process, then the switching behavior should be attenuated by years of physician experience, innate physician ability, and switching should lead to long-term improvements in patient outcomes. I'm not going to go into how I get at this in the data set, but I examine these hypotheses empirically, and I find that none of them are supported in the data. Taking all of this together, I conclude that this is unlikely to be a Bayesian process and that physicians are likely overreacting to salient adverse events. In conclusion, this study highlights one potential cognitive bias in a fairly high-stakes clinical setting. The setting is characterized by low transparency in that the patient does not usually know the adverse event rate of her obstetrician. There's high uncertainty even for the physicians because clinical guidelines are not cut and dry about when to use which delivery mode for which patient. And the choices made in this setting have significant health consequences for both mother and child. As for policy implications, when I've given this talk before, the most easily deduced policy implication has been that we should do things we should introduce organizational processes that sort of strengthen objectivity in the clinical decision-making space. And while that is true, I would just like to add a caveat that these considerations should be weighed against the fact that physicians are making very snap decisions in a very high-pressure environment, and any sort of process, such as documentation, paperwork, or oversight that would make them more risk-averse could hurt patients even more. So the question of how to attenuate this cognitive bias is in itself an empirical question. Thank you. Any questions? Thanks.
Really nice talk. Don Sullivan, Oregon Health and Science University. As a clinician, I do appreciate this idea of bias, that we're aware of it, but it's very hard to change your behavior. And I'm just wondering, for your analyses, how do you adjust for patient factors that may lead to one form of delivery or the other being medically preferred?
I am so glad you asked because I had to take this out from my original model, but from my original slide deck. But the way I have set up my empirical model, I won't go into this more, but the strengths of the empirical model that any correlated emitted variables are going to bias against my results. So if there is something that is happening to some patient level factor or a hospital level factor that is causing the adverse event to occur and the choice of the next patient's delivery mode, I should see no effect. So if anything, this is a conservative estimate. I hope that helps.
Hi, Nancy Schoenborn from Johns Hopkins. Great study, so fascinating. So I have two questions. One is whether the deliveries happened apart enough for you to look at the effect of time, whether that attenuates over time. And then second question is, if say, I don't know if this happened, but if say someone had a complication from both delivery modes recently, like how did that affect their behavior? Let's say 2 days ago, they had a complication from a C-section and 3 days ago, they had a complication from vaginal. Is it the most recent one that had the most influence? Just wondering if that came up.
Sorry. So the first question is time span. So I account for that. Well, in robustness checks, I reduce it to consecutive deliveries that occur in a 27-hour shift. That these effects stand, but they also stand when you look at longer, week-long time gaps. They do attenuate, but it's still there. So maybe sleeping it off, at least in the context of a week. I haven't looked at beyond a week. That is something I could definitely look at, but at least for a week, these effects last. And your second question was, oh, okay, so if someone has, but are you talking about the same delivery or is she having two separate deliveries?
No, I was wondering if she had two prior experiences that happened in two modes. So if she had a complication in one, let's say the most recent patient had a complication from vaginal, but like 2 patients before that.
Oh, great. I see. Yeah. Okay. Yes, this effect only lasts for 1 patient, accounting for, it fades very quickly, which is, I have a separate set of analyses showing that the fact that it fades so quickly is also evidence that it is an emotional overreaction. Otherwise, you would see that physicians who've had, that this effect should last at least a couple patients, controlling for the number of adverse events in the prior patient.
Thank you.
Yeah.
Really, really fascinating. Thank you for this work. I wanted just to ask as a clarifying question to make sure I'm interpreting it correctly, how you were utilizing the term elective when you talked about cesarean. Do you mean like scheduled cesarean deliveries, or do you mean that they were indicated off the floor? Like, so sorry, that's, yeah, how were you defining that term?
Okay, so, this is getting into the weeds a little bit, but
I'm sorry, I'm an OB, so I'm really curious
I can also talk to you offline.
Okay, that's fine. Also, then let me ask you another question then about the switches.
Yes.
So the switching notion is one that I'm trying to wrap my head around because it sort of places all the agency in the provider space. And I wonder how you attend to that in your sort of baseline assumptions that you're building into your modeling, because that's actually not how I approach the world, as that I'm choosing this mode of delivery for this woman or choosing this mode of the delivery.
Yeah.
And so I'm just wondering how
100%. And you would think, not you would think, that statistically, again, should bias towards null, because if the woman is driving her pregnancy, her delivery, then this should not occur, which means the effect size should get smaller, and you shouldn't see this at all. So
I think C-section makes sense with the choosing. I was actually trying to figure out how I choose vaginal, because I wish vaginal for everyone, but I feel like I don't get to choose it. But we can talk about it later, because I'm just trying to figure that out.
We've got time for one more question.
Okay, thank you again for the really fascinating presentation. My question is, do the physicians switch back to their original treatment option after they switch to this new one? And then also, my other question is, do you think that the adverse outcomes that are associated with switching can be because they're not used to that new treatment? They're usually doing that treatment A and switching over, and experience could be leading to that?
Yes, the second, absolutely. There's a lot of mechanisms that could be explaining it. There's a lot of them, but that is definitely one of them. And sorry, you
The first one was about, do they switch back to the original treatment after they emotionally
So
switch to the...
I don't know if that's what would that accomplish? Because switching back to the original isn't, I'm more interested in the match between procedure and patient type. There's no baseline delivery mode that they switch away from and switch towards. So I'm just looking at 2 consecutive patients, because then I can it's like I can look at the differences in consecutive patients. But when you look beyond one, that the underlying assumption is that the thing you did first was the thing you should be doing, which I don't know if that's true. But the effect only lasts a patient, so they, I guess, do switch back, but I don't know if that means anything by itself.
Okay, thank you.
Yeah.
Thank you, Manasvini.
I'm just gonna leave it up.
All right, for our final presentation, reading this oral abstract made me think about when I was an undergrad, when I was working as a server at a restaurant. And I was definitely warned about secret customers to help boost quality of the restaurant experience. And in this oral abstract, there'll be a discussion about mystery patients. So So the title of this presentation is Direct Observation and Feedback, Identifies and Improves Errors in Care.
It's not the final presentation, though.
My apologies, second to last presentation.
But that's okay. It's my final presentation, so that's fine. Thank you. Delighted to be here. I do have disclosures to make because this work was done as part of the Institute for Practice and Provider Performance Improvement. That is a business. I am a principal and director of that business. The project was funded by the Robert Wood Johnson Foundation with a grant to the American College of Physicians, which acted as fiscal sponsor for I3PI, and support was also provided by Horizon Blue Cross Blue Shield of New Jersey. So this has been a great session to be in, actually, because we've already talked about a lot of the things that I would have normally set this up with, which is what do we do when we're assessing care? And one of the things that we do is we look at the medical record and we look at claims data and we ask ourselves things like, are physicians delivering the recommended services? Excuse me. And we assume when we look at that, that the medical record is an accurate, more or less, reflection of the services that are delivered. Sometimes we also will survey patients and ask them how they felt about their healthcare experience, assuming implicitly that a patient can tell you if they are satisfied or not with their physician, and that means something about whether they got good care or bad care. Of course, plenty of other people have looked at limits of documentation, including Dr. Costopolo in this session. Sometimes we know that physicians document services that were not provided correctly or not provided at all. Sometimes physicians fail to document services that are being provided. And similarly, we know that there are all kinds of problems in selection and response bias with patient surveys. So the method that I've used for a dozen years or so in research and that we use in this company involves unannounced standardized patients or mystery shoppers, if you like. These are actors who present as real patients to physicians, portraying standardized scripts and documenting what actually takes place by means of checklists or covert audio recorders. We, in these projects, get the agreement of the physicians and the practices to be visited by these mystery shoppers, but they don't know when they're seeing a patient, whether that patient is a real patient or not. And we don't tell them until we've received a copy of their note so that we can look and compare the quality of documentation with the audio recording of what the physician did during the visit. The goals of this project, this grant, were to look at what the impact is of instituting a direct observation and feedback program using unannounced standardized patients on a set of targeted care behaviors, on the fidelity of documentation, and on the cost of care provided to the actual other patients of the physicians who were involved. So we had 217 visits to about 60 providers. Actually, they weren't all physicians. There were also nurse practitioners in this project, in 22 practices in New Jersey. These are practices that were enrolled in what Horizon calls its value-based program, meaning that if they did better on certain quality metrics, they would get additional reimbursement from the insurer. So the scripts and the things that we targeted to try to improve were sort of decided in conjunction with the practices. And with Horizon, they were things where the practices would get, had some incentive already built into the reimbursement system for improving them. So we had 4 different scripts, and I'll talk a little bit later about what the conditions were that were involved in those scripts. But in each visit, the unannounced standardized patient would see the physician, do a checklist of behaviors that we expected to see based on clinical guidelines that were used to develop the cases, and then we would code the audio recordings of the visit and the provider's note, and do that for a couple of visits for each provider, then deliver feedback at both the level of the practice and the level of the individual provider using written reports and phone coaching, and then we'd schedule a couple of follow-up visits so that we could look to see whether the things that we were targeting changed. So we compare the pre and the post-feedback care behaviors using logistic mixed effects regression. We compare chart fidelity, as I'll explain a little bit later, also using a multinomial regression. And then we, working with Horizon's claims data, identified a comparison group of matched practices that were in similar locations, similar volume, and getting similar levels of reimbursement as the practices in our study. And we got 3 months worth of claims data for all of our study practices and for these comparison practices before we delivered feedback, 9 months later, and 12 months later. So we couldn't do a randomized trial, but we tried to set up a sort of difference in differences analysis using two-part regression on claims data. And I'll later on, it'll be important that these are only claims for stuff that happens in an office visit. We don't have prescription data. And I'll explain why that limitation is really important later on. So the conditions that we were interested in this study included medication adherence in diabetes, opioids or avoidance of opioids for patients with idiopathic low back pain, depression screening and referral to treatment, smoking cessation, and breast and colon cancer screening. Diabetes and low back pain were particularly nice because in addition to getting visit-level claims data, Horizon, the insurance company, also has their own algorithm where they compute a per-member cost for members with diabetes and with low back pain for all of the stuff that goes on for that member during the year associated with those conditions. And so they provided us with those patient-level costs as well. So here are the quick version of the results. In the pre-feedback setup, when we were just sending patients in, we had this list of behaviors that the physicians were supposed to do. They were doing about 46% of them. In the follow-up visits after we had done the feedback, they were doing about 56% of them. So that's better. Still not great, but better. And you can see that a lot of the improvement, and these are in order of improvement, came in things like smoking cessation and screening for depression, and then addressing depression and a little bit in back pain. When it came to some of these other things, cancer screening and medication adherence, we didn't really move the needle very much for these providers. When you look at chart fidelity, we thought of this as a sort of 4 categories you could be in. We could hear something in the audio, something went on in the visit, and it could be documented in the chart, right? A review of systems took place, and the chart says there was a review of systems, and it says what actually happened in that review of systems. That's the green bars. And from the pre to the post in the upper left corner there, that did go up, which was what we had hoped to see. Why did it go up? Primarily because the 2 things on the bottom went down. The one on the left, documented but not heard, is a pretty serious concern. So that is something was in the note, like normal foot exam on a diabetic patient. And from the recording, it is clear that no foot exam took place. So this could be caused by a variety of things. I tend to think physicians want to do the right thing, and this is caused by a lot of the copying and pasting and templating that was alluded to earlier. But that's bad, and we were able to reduce that by calling attention to it through these unannounced standardized patient visits. The other thing that went down were these things that were neither heard nor documented. So these are things that didn't take place, and so they shouldn't have appeared in the chart, and more of them didn't appear in the chart, if you like. When we look at cost, we had an interesting sort of anomaly that I don't have an explanation for, maybe somebody else does. It doesn't bear on our comparison, but in the early claims period, before we had done the study and the feedback, you can see there were a couple 100,000 claims in the data for those 3 months, totaling $17 million. In both of the later periods, the number of claims goes up and the cost of claims goes way up. Now, this is across an insurance year. So I assume something changed in reimbursement, or I don't think that's just utilization alone, but something clearly happened. You see it all over the place. It's that big slope at the beginning. What was of interest to us is the spread between the curves. So we're looking at predictions of claims for visits where there wasn't a 0 claim. And we saw, as we had actually expected to see, that when it comes to diabetes, our study group, when we look at what's going on in terms of the claims, we're saving money because physicians are talking more about taking your medicine, and we're seeing fewer visits for complications of diabetes that might be associated with not taking your medicine. Low back pain goes the other way, right? So with low back pain, what we see in the claims is physicians are now referring more to physical therapy than they used to. Physical therapy costs money, and we see those costs in these claims because we see office-based procedures. We don't know that opioid use, for example, is going down because we don't see the prescriptions. But we do see other changes in practice behavior that would be consistent with what we would hope to find. Similarly, cancer screening is more costly when people start doing more of it because it takes place, at least for these cancers, as billable office kinds of things. We saw the same pattern when we look at the per patient claims. If you look at the difference in difference per patients, costs go down for taking care of diabetes. They go up for taking care of low back pain, again, because of things like physical therapy. Obvious limitations that we could talk about later. The practices that were in the study were volunteer practices, so although we tried to match them, there may be some selection bias there. And the lack of access to prescription claims really makes it hard for us to draw some conclusions about things like opioids in particular. So the next time around, it would be great if we got those. What's important for us, and I think new here, and I feel like the take-home message is, we have shown before that by using unannounced standardized patients, you can hold up a mirror to practice and help people change and improve their practices in ways that they care about. This is the first time that we, or we think anybody else, has shown that you can trace changes thereafter in the terms of the claims made for caring for actual patients. And I will stop there and take questions. Hey, Mary.
Hello. I thought everyone was going to be rushing up. That was fascinating, and I wanted to ask a question about your choice of putting some of the behaviors together, whether you think it's different with some behaviors versus others. I was thinking about diabetes medication where it's a patient behavior that has to happen versus a physician referral or a physician prescribing or not prescribing something, and wondered if you had any thoughts about why there might be differences in some of those outcomes.
Yeah, I think that's a great question, and we can't really trace that in the actual patients, but we can look at some of that with the unannounced standardized patients. What did the physicians actually do? So our actors are not going to make life terribly difficult, right? We're looking to see, did the physicians say, oh, you really should be taking your medicine, or oh, let's figure out what's going on. Why are you not taking your medicine? Or did they notice this patient had a positive depression screen and do anything about that at all, right? So I think it is probably, we do try to make this something that's possible for the physician to modify, at least when they're dealing with the mystery shoppers. So I think we can put most of this as, like, we're not looking for the patient to take medicine. We're looking for the physician to say, why aren't you taking your medicine?
And do you think by doing that, noticing it, that because you're showing this direct cost relationship with some of this through this observation, maybe that doing something about it has this downstream implication on behavior?
Yeah, so it's very kind of you to call it a direct relationship.
Well,
I think it's not very direct at all, but that's the inference that we are trying to explore.
Correct, that's what I meant,
Absolutely.
right? You're linking those two things. I think that's
Absolutely.
pretty fascinating, that just by the noticing that has those potential downstream effects. Thank you.
Thank you.
I think we don't have time for further questions, so thank you so much,
Catch
Alan.
me afterwards.
Now we will have our last presentation on how capacity constraints affect physician decision-making in the ICU, strained and constrained, by Manaswani Singh.
Okay. Hi again, everyone. I will be presenting another paper for my dissertation, this time with my wonderful advisors, David Howard, who's in Atlanta right now, and Tom Valley, who's right there. Okay, so, just a little caveat. This is a working paper in that we have shown a lot of what is happening, and now we're working on showing why that's happening. Okay, so an overview of the paper. Do increases in ICU capacity affect a physician's ICU admission and discharge decisions? We find that yes, and I will come back to the temporary or permanent thing in just a moment. Do they lead to inappropriate use of the ICU? For sepsis patients, it certainly appears so. Do they improve patient outcomes? No. Why is something we're still working on. All right. So ICUs are costly. There are few clinical guidelines to inform use, as a result of which use varies widely across hospitals and physicians. Now, this could reflect either patient need for or inappropriate use of ICU beds. Which one is it? This is a hard question because of the endogeneity between number of ICU beds and the use of ICU beds, where both of them are determined by patient ICU need, which is inherently unobservable. So in this paper, we try to estimate the causal effect of two types of shifts in ICU capacity on physician ICU decisions. One, what we're calling strain, which is temporary hourly fluctuations in ICU bed availability. And two, what we're calling expansions, which is an actual physical expansion of the ICU, which adds more beds to the unit. And if you're in the field, you're probably wondering, why do we need another study on ICU beds and ICU use? And I'm here to tell you that there are three reasons why. One, we move away from hospital level analyses. And in fact, we actually look at what a physician would do or does when she has fewer ICU beds, and then what that physician does when she has more ICU beds at her disposal. We have a really great data set, which allows us to observe many things. But most of all, it gives us access to all the tests ever ordered and all the results to those tests, which allows us to triangulate towards objective measures of patient ICU need, which is really necessary for this sort of question. And third, we differentiate between temporary and permanent capacity changes. All studies in this area right now either look at increases in ICU beds or some crude version of temporary changes in hourly ICU bed availability. Underlying these two kinds of studies is the assumption that physicians respond in the same way to temporary and permanent capacity shifts. However, we argue that a physician's use of the ICU depends on the number of beds that are at her disposal currently in that hour, but also that response in itself depends on the total number of ICU beds in the unit. Okay, so I have 100% inpatient EHR data over 3 years from 2 academic hospitals, each of which had an ICU expansion at 2 different times. I have about 140,000 patients. My independent variable is a triple interaction between an indicator for post-expansion, a continuous measure of ICU strain, which is just how full the ICU is at a given moment in time, and patient characteristics, which we will come back to in a moment. I have 2 groups of dependent variables, measures of ICU use and measures of patient outcomes. But for this presentation, I'm just going to focus on ICU admission and in-hospital mortality. Okay, back to the question. Do increases in ICU capacity affect a physician's admission decisions? And to orient you to the graph a little bit, the x-axis over here is a measure of ICU strain. As x increases, the ICU gets more full at the time of the patient's hospital admission. The y-axis here is the probability of the patient's ICU admission. Now, what is happening pre-expansion? Pre-expansion, if we just use comorbidities as a proxy for patient need, then we say that pre-expansion, more comorbid patients are being admitted to the ICU more than less comorbid patients, understandably. But also, as the ICU gets more full, both types of patients are being admitted less to the ICU. Now, what happens post-expansion is there's just a baseline shift in both of these effects. Both types of patients are being admitted to the ICU at all levels of ICU strain. Now, comorbidities is a crude measure of patient ICU need. Can we get at an objective measure of ICU need? And for patients with sepsis being one of the most common reasons patients are admitted to the ICU, it looks like we can. So, Sepsis 3 defines sepsis as life-threatening organ dysfunction due to infection and proposed operationalizing the detection of such sepsis as an increase in the SOFA score by 2 or more points from baseline, based on analyses that such an increase is highly predictive of hospital mortality in patients with suspected infection. Moreover, the CDC recently released a simplified version of the SOFA called the eSOFA, which is optimized for electronic health records itself. So that's what we use for this analysis. We limit the data to patients with suspected infection, that is, have tested positive for a blood culture and were put on antibiotics. And then for the patients who experience a 2 or more greater point increase in the ESOFA score, we identify them as ICU appropriate, and the rest of the patients, we identify them as ICU inappropriate. So, reframing the graph we just saw using this new measure, we see that the probability of ICU admission between ICU appropriate and ICU inappropriate patients becomes much bigger. And because it becomes much bigger, and I'm trying to show both these things in the same graph, it's harder to see, but there's still a negative effect of ICU strain on ICU admission for both types of patients. Now, what happened post-expansion? Post-expansion is when things get interesting. The green line, which is the probability of ICU admission for ICU appropriate patients, we see that there's no significant increase in ICU admission for them. The blue line tells us the probability of ICU admission for ICU inappropriate patients. And we see that at all levels of ICU strain, ICU inappropriate patients are admitted more to the ICU. Now, perhaps some of you are thinking that maybe they're not really inappropriate. Maybe physicians are just trying to get ahead of sepsis by putting people with suspected infection into the ICU. And that's probably what's happening, but just a reminder, the ICU is not supposed to be used as a preventive measure. That is, you are already in the hospital for that. Perhaps some of you are wondering, so what? What is the harm in admitting ICU inappropriate patients to the ICU? And that's exactly what I asked next. How do capacity expansions affect patient outcomes? And this graph, actually, the y-axis is the probability of in-hospital mortality. We see that pre-expansion, of course, the ICU appropriate patients have a higher likelihood of dying than ICU inappropriate patients. They're just a lot sicker. Also, interestingly, unexpectedly, as the ICU gets more full, there's a slight incline in the probability of dying if the ICU is full. Post-expansion, look at the blue line. ICU inappropriate patients who are admitted more post-expansion have no significant effect on in-hospital mortality. Look at the green line. ICU inappropriate patients who are not being admitted more to the ICU actually have a greater likelihood of dying, and this is being driven at times when the ICU is very full. So again, if some of you are wondering, maybe the ICU expanded and the hospital is admitting sicker patients. I have it in the appendix. It's actually not, the hospital is not admitting any sicker patients. So this is something we're trying to disentangle right now. Hopefully next year you'll see me with an answer to why this is happening. But I just wanted to give you some takeaways because conclusion doesn't seem like the correct word here. One, ICU strain across the board reduces bed use. A patient is more likely to fill an ICU bed post-expansion than pre-expansion. The patient who fills it post-expansion is likely to not need it, and the patient who needs it has worse outcomes post-expansion. And with that, thank you.
Thanks for an excellent talk.
Thank you. Bob Dittus of Vanderbilt University. During this period of time, the Society for Critical Care Medicine was doing their ICU Liberation Project, and there was a lot of movement in ICUs to adopt the bundle of care, which is shown not only to address delirium and reduce mortality and morbidity, but in fact to reduce length of stay in the ICU by 30% or so on experienced. Can you tell me about these particular hospitals, where they were in that journey, and whether this may have an effect on your observations of the even more enhanced capacity of ICU beds beyond just the ones they built?
That's a great question. In my talks with the chiefs of the intensive care units at these hospitals, that hasn't come up. I will ask them specifically and see if that's been affecting things. That's very possible.
Hi, I'm Rafi Sharak. I'm from the Albert Einstein College of Medicine up in the Bronx. Just first wanted to say amazing presentation. I really appreciated you defaulting to female pronouns when talking about doctors to help combat a little bit of that implicit bias that we have. My question was just, did you look at, and was there any difference in who made the admissions decisions in the hospitals that you were looking at? Was it the emergency physicians? Was it the internal medicine docs on the floor, in terms of where patients who got admitted, where they went?
That's a great question. unfortunately, we can't get at who makes the decision. We can see who the attending is, and we can see the intensive care, the intensivist involved in the procedure, but we're actually currently working on trying to get they call someone, and then that person tries to connect them to empty ICU beds, and it's turning out to be a little bit harder to get than than we thought, but. Yeah. Oh, is that what you were asking? Yeah. That we can definitely do, and no, we haven't looked at that yet. Sorry.
Rob Ham, University of Oklahoma. It's concerning that when they expanded the number of beds, that the rate of death of the sepsis people died. I wonder if they also expanded the manpower, or did they just increase the amount of responsibility that each worker had?
Yeah, I think they expanded them to fill up the additional ICU, because I know that there were lots of calls for intensive care nurses that went out. I'd have to see if they were able to fill it. Maybe they weren't, but that's actually sort of one of the things we're working on all these potential mechanisms for why that could be happening. And one of it is just they're not overcrowded in the sense they're not enough beds, but there's just not enough manpower to take care of it. And also other things like if you fill a bed now, maybe you're not able to forecast the future better. So when the sicker patients do come, they've been filled by the less sick patients. So there's, again, the why is a very important part of all this, for sure.
Thank you for this interesting presentation. I was wondering, I know you focused on sepsis here, but is there any benefit that you might have found in expanding the ICU? And also, can you remind me the magnitude of the expansion?
Oh, so we use sepsis because when we talk to the people in these hospitals, the chief of staffs and everything, they mentioned the SOFA as being used to determine patient ICU need, and it's a really clean way to segment patients into potentially inappropriate and potentially appropriate. That's the only reason we used it. And there's other people with other illnesses. It's really hard to say. Even the EHRs don't perfectly capture how sick a patient is. So that, and I'm so sorry.
The magnitude of the expansion, please.
One expanded by 15 and the other expanded by 6.
Okay, thank you so much.
Yes, we've got time for one more question.
Hi, Joanna Hart from the University of Pennsylvania. I just have really one but two quick questions. So you defined septic patients as being bacteremic, you mentioned at one point, so they had to have a positive blood culture prior to ICU admission?
At any time.
And my second question is really about whether or not you looked at, when you were identifying strain in the ICU, did you only look at capacity, or you also looked at how sick the other patients in the ICU were?
That's a fantastic place to take the study, but we haven't looked at the combined acuity load of the ICU, and that is fantastic, absolutely.
Yeah, thank you. I would like to thank all the speakers, also on behalf of the organizer, and I would like to thank you as an audience asking that really great questions. Thanks.